Assalamu alaikum. Today I'm going to share with you a case of a young 35-year-old man with subluxated lens. The zonules were intact, and I have decided to proceed with this case using a capsular tension ring. I stain the capsule minimally because I'm afraid that the dye may cross through the zonules and stain the posterior capsule and enter the vitreous. As you can see, the capsule does not tear, and there is wrinkling of the capsule and movement of the whole nuclear complex. Therefore, one of the tricks that I usually employ in these cases is use counter traction with another instrument so that it will be easier to pierce the capsule. This is a 23 gauge needle, so a straight needle. So I use the 26 gauge needle to stabilize the bag and use the 23 gauge needle to pierce the anterior capsule, and here I'm able to create a flap. And now I'm using the 23 gauge needle to guide the flap. As you can see, the complex is still moving, so I decide to stabilize the nuclear complex with an iris hook, which I am going to use in this case for as a capsular hook. So I hold the bag in the subluxated area with a hook so that it acts as a counter traction measure to prevent the bag from pulling toward the side where I'm applying force to tear the capsule. Now I'm using a utrata forceps to complete the rhexis. This patient had a deep chamber, so it was difficult to hold the capsular tag, and after it reached the subincisional area, I thought it would be better to continue the rhexis with a forceps, with a micro forceps going through the side port. That would be a better vector for tearing the capsule. In this case, where the lens was subluxated and the whole capsular bag was moving during the capsular axis. And now I'm successful in creation of the capsular rhexis. However, it is an oval shaped rhexis. I decided to maneuver the lens out of the capsular bag to prevent further stress on the zonules. As you can see, this patient had grade 3 nuclear sclerosis. And I do not want to perform any chopping maneuver in the bag lest I damage the zonules. Now I'm able to prolapse the nucleus out of the capsular bag so that it will make my life much easier. The phacoemulsification step was routine. Do a traditional chopping maneuver. Impale the nucleus with the phaco tip between the phaco tip and the Sinski hook and gobble the pieces down. This part of the surgery was routine, nothing unusual. Now, after removing the nucleus, I decide to put in a CTR, a capsular tension ring. This was a capsular tension ring of 13 mm diameter, one on the larger side. So it was difficult to. This was the only one available, and it was difficult to put it in the capsular bag because the capsular axis was small. So now I will use a double dialer technique to place it in the capsular bag. However, one of the dialer accidentally slips out of the inlet of the CTR, and now I am facing some difficulty in maneuvering the CTR. As so I use a micro forceps to guide the CTR out of the angle of the eye and hook it onto the Sinsky hook. However, since the CTR was placed vertically, the hook accidentally entered the CTR and now it is stuck in the CTR, as you can see, because it was perpendicular to the hook. If the CTR is perpendicular to the hook, the inlet will become stuck in the Sinsky hook. Now it is horizontal, so now it will not be stuck, and here I am successful in placing the CTR in the capsular bag. Removal of the cortical sheet was a challenge in itself because the CTR prevented me from the sheet got trapped because of the CTR, and because the bag was the lens was subluxated in this particular quadrant, so it was difficult. However, with some persistence and tangential stripping, it is very important to tangentially strip the sheets, not centripetally, tangentially. I was able to clean the capsular bag and remove all the cortical sheets. And the whole complex is moving. It is important to observe here that I am not pulling centrally, I am pulling sideways or tangentially. If the sheets are stuck because of the capsular tension ring or because of the subluxated lens, then always pull tangentially. Now place a single piece hydrophobic lens in the capsular bag. At this point, I was afraid that the bag might be distance of the bag because a lot of force was required to push the IOL in the bag. However, I was successful, and now you will observe I'm cleaning up removing the OVD, the viscoelastic, and some of the viscoelastic has crossed the zonules and entered the posterior segment. I hope you enjoyed the video. Please give any comments and suggestions. The patient did very nicely. Jazakallah. So I hope you enjoyed the surgery. In this case, it is important to use all the tools available to perform the surgery safely. You can use CTR's capsular hook, micro forceps, and all the tools available so that you can perform the safest surgery possible. The cortical sheet should always be stripped tangentially, and finally and last of all, you should exercise a lot of patience. Thank you.